One of the most important aspects in transplantation is the immunological aspects. Today, I'm going to focus on an update of immunological aspects in renal transplantation. So in this topic, I'll summarize what I harvested from more than 140 articles. And so the focus will include what is the update in the HLA matching, what the importance of blood grouping, RH, bioincompatible blood groups, antibodies and HLA antibodies in focus, and what about transplant biology and biomarkers, immune exhaustion and senescence, transplantation and microbiota, and I'll end with the European best practice guidelines in immunological monitoring. To start with, this is one of our articles that was reported by Professor O'Neill and his colleagues regarding the factors affecting graft survival among patients receiving kidney from live donor as a single center experience. I have the great honor to have this photo with him. In this study, if you look here to the DR mismatches, the lower the mismatch, the better the graft survival you will find. So if the mismatch is 0, 5-year survival is 91%, and 10 years, 77%. But if you find one locus mismatch in the DR, this 5-year survival decrease from 91 to 86, 5% drop, and 10 years from 77 to 64, 13%. So if you find zero mismatch, this is a better survival. If we look at class 1, HLA, B, and DR, the total score ranges from 0 mismatch up to 6 mismatch. We don't transplant 6 mismatch. So if you look here to 0 mismatch, 5-year survival is 94%, 10-year survival is 79%. And if you compare zero mismatch with other mismatches, you find the higher the mismatch, the lower the survival at 5 years and 10 years. This means better HLA matching is important and associated with better survival outcome. And zero mismatch has its repercussion on the live donor kidney transplant outcome. From the update point of view, this is one of the articles discussing this issue, rethinking the advantage of zero HLA mismatches in unrelated and related transplantation. If we look here at the unrelated transplantation, in this study, they reported 83 patients, zero mismatch in unrelated transplantation in live donor transplant. And when they compare them to 407 well-matched in the demographics, you will find here up to 12 years follow-up, there is no difference in the probability of this censored graft survival. So zero mismatch has no repercussion on unrelated transplantation. And when they looked at the data of these 83 patients versus more than 30,000 patients live donor unrelated kidney transplantation, again, there is no difference in graft survival between zero mismatch or higher than zero mismatch in unrelated transplantation. This is to the contrary of live related donor kidney transplantation. Here, zero mismatch, 9,000 versus 90,000 of more than zero mismatch in the live related. You will find here after 12 years, there is survival advantages of approximate 13%. So, although zero mismatch lost its importance in the unrelated, but it's still very valid in live related donor transplantation as we found in our transplant series. So the question, why we have zero mismatch and still we have loss in the graft? Because this may be due to the mismatch in the minor antigen or mismatch in major antigens that we don't measure. And one of the new era is to look at the HLA epitopes as viewed by antibodies. So if we look at the structure of HLA, this is amino acid sequence here. 3 amino acids constitute triplet inside this zone. But with this architecture, there is here this amino acid plus here amino acid. This is ablet. So you can find antibodies against this ablet. So you can find donor and recipient matching in the HLA, but there is mismatch in these ablets. So again, there are refinement in the tissue typing, and the HLA matchmaker is an advancement and of high resolution to HLA typing. The second part of this presentation is blood group. Here, this is a very nice editorial comment on the ABO incompatible transplantation. By ABO incompatible, I mean to transplant A kidneys to kidney from A blood group to recipient with B group, A to B or B to A or AB to O, whatever. Here in our center, we depend upon the crude blood transfusion rules. So O can give to O or A, and AB can take from all, O can give to all. So this is our rules, but we have no experience in transplanting A to B or B to A or AB to O. So if we look at the centers that have experience in ABO measure incompatibility, they found that ABO incompatible transplanted patients had 1.9 times the risk of both death and graft failure compared to ABO compatible patients. So even if you have the experience and you have the facilities for dealing with major ABO incompatibilities, because they do desensitization by plasma exchange, IVIG, etc. Again, the results are not like the compatible blood groups, to the extent that the editorial comment title of this article is ABO incompatible kidney transplants twice as expensive because of the drugs and maneuvers used to remove the isoagglutinin, because if the patient has blood group A, he has antibody against B. So to get rid of B, we should do the procedure plasma exchange, immune adsorption, IVIG, plasma rituximab, etc. to reach a certain level of this isoagglutinin to be sure that you can do transplantation. So it is twice expensive and half as good, because increasing 1.9 times the risk of death and graft failure. In the extension of blood grouping A2 story, because we look at A2 as O, so we can consider A2 to be, or A2B, because A2B behaves like B2B. What is the past, present, and future? I think this cartoon summarizes all the experience. If you have B candidate, the recipient is B. So first, measure the anti-A titer. If anti-A is less than 4, you can consider a donor B or A2 or O, A2B. So A2 is considered like O, A2B considered like B, or B, and this will increase and expands the donor pool for the B candidate. But if the patient has titer anti-A above 8, this is contraindication to A2, either A2 alone or A2B, and should be restricted to B donor. Another question, does RH make a difference? This is one of our articles that was published since more than 1 decade, included 1,500 live donor kidney transplant that were carried out at Mansoura Regional Referral Center. Professor Yasser Osman and his colleagues published this work and showed that there is no difference in the outcome between HLA mismatch, positive to negative, than matched RH, positive to positive or negative to negative. So in our experience, we don't have any impact. We don't have any impact for RH in our series. But I think from the OBELs and others, they showed that RH incompatibility may make a difference. Another important case, there's a 39-year-old woman in the stage kidney disease and received kidney transplant. The blood group of the recipient is A positive and the donor is A negative. So here the transplantation from A negative to A positive, is there a problem? You can say if we look at the blood as as blood transfusion, we can say A negative to A positive, it's okay, no problem at all, because we transfer blood from A negative to A positive. Here, the problem, after 2 weeks, the patient, the recipient, this woman, suffered from hemolytic anemia and jaundice. The question is there a link between the difference in RH between the donor and the recipient, negative given to positive, and the occurrence of hemolytic anemia? The differential diagnosis may include hemolytic anemic syndrome, but if you examine the blood, you will find no schistocytes, so it's less likely. Is it autoimmune? Less likely, because autoimmune doesn't occur in this early period with the immune suppressive drugs used. So what is the reason? What's the story behind this? The story is when we transplant a kidney, so we take a kidney from a donor, A negative, and with this transplanted kidney, the lymphocyte transfer from donor to recipient. The lymphocytes in the donor lymphocyte doesn't see positive RH. So when the lymphocytes that were living with negative RH and now transferred to a recipient with A positive may be sensitized and release the antibodies that lead to hemolytic anemia, antibodies against RH, leading to hemolytic anemia. The same if we transplant O to A. So the kidney from the lymphocyte within O don't see A or B. So when these lymphocytes are transferred within the graft to a recipient with A or B antigen, this lymphocyte may lead to formation of antibodies against A or B and leading to hemolytic anemia. This is one of the articles from Cairo University. They had kidney and liver transplant, and they had 4 cases of this hemolytic anemia. And the explanation is the bathing of this lymphocyte. So this is messenger lymphocyte syndrome or alloimmune hemolytic anemia. Allo because the lymphocytes which are responsible about the release of antibodies come from the donor, not from the recipient. So it is allo cells. So it is alloimmune hemolytic anemia, messenger lymphocyte syndrome, or graft versus host disease. This is our experience. We had 10 cases that were published since 6 years. Hemolytic anemia after ABO, non-identical living donor kidney transplantation, O to A or O to B. And we found at that time cyclosporin is precipitating factors or adding factors. And our experience is this alloimmune hemolytic anemia is spontaneously recovered. Sometimes the patient may need blood transfusion, and in this case scenario, we should give blood compatible with donor and not recipient, so to be free from antigens. And secondly, the percentage of occurrence of messenger lymphocyte syndrome is not uncommon. It occurs up to 7 to 9% in renal transplantation. It usually occurs more frequently in lung and cardiac transplantation because the transferred lymphocyte mass will be bigger in this transplantation. If hemolytic anemia becomes aggressive, and the treatment may include plasmapheresis, rituximab to inhibit the transferred lymphocytes, and or IVIG. Regarding actually antibodies, B cell is very important because it matures to plasma cell that produce antibodies against the graft. One of the important points is to respect T cell mediated rejection, because this is a rejection, inflammation, and it may lead to sensitization. So T cell mediated rejection may lead to antibody formation. So the relationship between T cell mediated rejection and antibody mediated rejection is bidirectional. And here, this is an interesting paper showing that the major cause of graft failure is antibody-mediated rejection, either to the development of acute antibody-mediated rejection, and this is the consequences, or because of non-adherence. Whatever the reason, antibody-mediated rejection should be respected. And to be respected, we should have a good match. We should think and thoroughly evaluate for the presence of anti-HLA antibodies. And this is one of our publications from Urology and Nephrology Center. Here, this was the idea of Professor Ghanem. We had the sera of these patients, 153, stored in our lab, and these patients were transplanted for 4 years. And then we had the Luminex technology, and we applied Luminex technology to detect anti-HLA antibodies in the sera stored before transplantation. And we found 104 patients had no antibodies by Luminex, 33 had donor non-specific antibodies, and 16 patients had donor-specific anti-HLA antibodies. For these 16 patients, 5 had antibody-mediated rejection within the first 2 weeks of transplantation. This means that the presence of donor-specific anti-HLA antibody by Luminex is associated with significant higher risk of acute antibody-mediated rejection. And this is one of the updated articles still accepted for the showed that class 2 antibody activates the endothelial cells and promote Th17 and disrupt regulated T lymphocytes. So class 2 and DR antibodies are important because it leads to pathology. What about DP? We don't do DP routine antibodies, and this study addresses this issue, that the presence of DB alone is rare, but it may be present with other donor-specific antibody. When they do the analysis, they found that the merely presence of DB had no significant difference, doesn't make difference, but the difference is in the presence of donor-specific antibody. So there is no need to routinely monitor DB antibodies. Regarding DQ, this is one of the articles that reviews this issue, anti-human leukocyte antigen DQ antibodies in renal transplantation. Are we underestimating the most frequent donor-specific allo antibodies? And this is very important because if you look at the data of North America, if you look at DR, for example, DR3, it is 12%. What about DQ3? It is 27%. So DQ3 is more common in North America than DR3. So the anti-DQ antibodies are so frequent. And this article includes this table that summarizes the results of the literature about the value of DQ antibodies. And the presence of DQ antibody is associated with acute antibody-mediated rejection, increasing the risk of chronic antibody-mediated rejection and transplant glomerulopathy, and adversely affect the graft survival. One of the important points in Luminex, when we explain Luminex in one of the previous presentations, we said that Luminex just detects anti-HLA antibodies and doesn't tell us if these antibodies bind the complement or not. Complement, even cytotoxicity cross-match shows that complement binding because we add complement and incubate. So if there is an advantage to know the nature of antibody, if it binds C1q or not, this was an innovation in the Luminex technology. So we can do the Luminex technology and know well if this antibody binds complement or not. But again, a lot of debate in this issue, and it still needs further validation. So it is not validated yet. The same for C3D binding. We can predict C3D binding in the sera by the use of Luminex technology, and the detection of the C3D binding donor-specific anti-HLA antibodies and its correlations may correlate with the graft outcome. But still, we need further validation for all these serological technologies to predict the pathology in the tissues. An interesting article included 500 patients, 90 patients were living donors, and 318 deceased donor. Here, they consider the biocompatibility by the absence of anti-HLA antibodies, donor-specific anti-HLA antibodies. So if the anti-HLA antibody, donor-specific anti-HLA antibody, is not present, irrespective to the flow cytometric cross-match, they proceed for transplantation. And they found interesting data because here there is no difference between the flow positive or flow negative so long as anti-HLA antibody, donor-specific antibody is negative. Here the same, but they look at T or B or whatever. So again, there is no difference between flow positive, the presence of antibody donor specific or not, so long, the flow cytometry positive or not, so long as the donor specific antibody Biomarkers is negative. So virtual cross-match means the presence of anti-HLA antibodies detected by Luminex. And when we look at the tissue typing of the donor, we find the same antigen for the antibody present within the donor tissue type. So the recipient blood has antibody directed against the tissue typing of the donor, so this donor is specific. Again, we cannot recommend the routine use of anti-HLA antibody detection depending on virtual cross-match in live donor transplantation. And still, this interesting data showing the role of anti-HLA antibodies. Non-traditional antibodies include HY antibodies. These are antibodies formed in women when they receive kidney from men. And the anti-MICA antibodies, MICA, it is major histocompatibility complex class 1 related chain. The problem is, in this study in New England paper, they found that the positivity of MICA is adversely affected graft survival. The problem is MICA antigen are not present within lymphocytes, but are expressed on the endothelial cell. So if we look at the cross-match, you'll find the cross-match negative, either CDC or flow cytometry, because CDC or flow cytometry cross-match depend upon the reaction of donor lymphocyte with patient serum. So we cannot detect the presence of donor-specific anti-MICA antibodies by the traditional cross-match. But if we want to look, we'll look by Luminex with special kits for MICA or by endothelial cell cross-match instead of lymphocyte cross-match. And this is one of the applications. This is just abstract, and they select a case compatible regarding the absence of anti-MICA in the second transplant to avoid the sensitized patients against MICA antigen. Up to this moment, we cannot recommend MICA tissue typing. Another autoantibodies that was discovered since 1 decade or more than 1 decade, and this is the autoantibodies against angiotensin II. It is antibodies, but it reacts as agonistic antibodies, so it stimulates all the mechanistics of angiotensin II, vasoconstriction, and the pathology in the tissues. If we diagnose antibodies directed against angiotensin II, the treatment is to use plasma exchange, etc., plus losartan. Losartan will block the receptors and avoid the action of these antibodies. Again, the next sector is translational biology and the biomarkers. The biomarker era intend to predict the pathology. So here we have antibody-mediated and T-cell mediated rejection. For antibody, the best biomarker is the presence of anti-HLA antibody donor-specific antibodies. But for T-cell mediated and non-specific, you can find a lot of mediators, a lot of issues like perforin, granzyme A, granzyme B, FOXP3, fast ligand. All these can predict T-cell mediated. This for CD8 and for CD4, TIM3, chemokine 10, 9. All these needs further validation. So we are convinced in our practice with the donor-specific antibodies, detection by Luminex, but we are still not convinced by doing the biomarker for the T-cell mediated. Although I am saying that I am satisfied by DSA era, but does DSA is enough? Does DSA enough? The answer is no. Detection of the humoral antibodies, we need more than serum antibody screening by looking at the memory B cells or memory T cells. Here I am going to comment on this article, interferon gamma, spot testing as a risk stratifying biomarkers for kidney transplant injury, a result from CTO2 multi-center study. In this study, they found that the detection of memory T cell by interferon gamma early spot testing is beneficial if the patients are not induced by ATG. But when they are induced by ATG, the presence of memory T cell has no role in predicting the occurrence of rejection. Another important issue, Silex-based immune no. This test depends upon measuring the activity of T helper cell in vitro by stimulating the T helper cell in vitro by exposure to phytoagglutinin, and then measuring the production of ATP by T helper cell. If this production is less than certain figure, or within a certain figure, or above certain figure, denotes something. So if T helper produce a lot of ATP, above 500, something like that, this means that this cell is very active. So we may predict rejection. So if the Silex shows high ATP production by T helper cell, our action is to enhance immune suppressive drugs. And if the production is very low and suppressed, this means that the T cell is very suppressed. This means that the patient is liable to infection or malignancy. In this scenario, this situation, we should reduce immune suppressive drug. If the result of ATP is in between and within the therapeutic range, it's okay to keep the immune suppression as it is. And when they looked at all studies in this meta-analysis, they found that there is no predictability, and they cannot predict exactly as we thought. A lot of innovations regarding non-chimeric HLA identical renal transplant tolerance, showing the immunophenotypic and genomic biomarkers. If you look here to the study of tolerance, here they look at the continued immune suppression by this protocol, and ends here with no immune suppressive drug. If you look at patients with tolerance, you'll find the Treg cell is higher folds in Treg cell. And again, there is in the bioinformatics innovation known as MIRNG. What's MIRNG? It is minimum information for reporting immunogenomic by the next generation sequencing, HLA typing, and this is the website mirng.immunogenomic.org. One of the pathways in the biology is interleukin 21 cytokine and its receptor. A stimulation of the receptor by interleukin 21 signal inflammation and promotes inflammation and against the tolerance. So this pathway is under experimental studies to tell us in the future about how to use the treatment for this pathway. Regarding the chemokine trajectory within the first month and third month, this is the chemokine 10 to the creatinine. If it is less than 2.79 nanogram per millimole creatinine, this is the prediction of no rejection. If it's above, it may predict rejection, and the same within 3 months. So the higher the urinic chemokine, the higher the risk of rejection. However, it may be found with PK virus. So if you find chemokine in urine is very low, this reflects immunoquiescence and absence of rejection. So this is why we can use it in a negative way. Early low urinary chemokine 9 and 10 might predict immunological quiescence in clinically and histologically stable kidney recipients. One of the most important pathways is the mononuclear phagocyte system, because it is one of the adaptive immunity and control the innate immunity. It is one of the innate immunity system, most important innate immunity system, and also has some correlation with adaptive or T and B cell, because it can infiltrate the graft and lead to graft destruction. So to know the secrets of this pathway, phagocyte system, in organ transplantation, it will be very fine. And when we transplant a kidney, you may find phagocytes coming from the donor and phagocytes of the recipient himself. And this is the pathway. The dendritic cell has, this is a human and this is a mouse, and these are the markers. And this is the conventional DC, the dendritic cells, plasma, cytoid dendritic cells, the classic monocytes in the blood, non-classic monocytes, monocyte-derived macrophages, and all these are the markers, and resident macrophage, and resident macrophages have all these markers. One of the important pathways here, if you look, this is the RHO-dependent kinase, and when you inhibit this kinase by the use of Y27632, this will change the shape and function of a macrophage. This is the normal macrophage by scanning a microscope, and this is by special staining. This is the macrophage showing bipolarity, means we have two poles, leading edge and trailing edge. If the macrophage like this, the macrophage is functioning well. And this is, and here, if you apply the Y27632, the macrophage changes from the bipolar into rounded structures and lost its polarity. The macrophage lost its polarity, and this is untreated macrophage bipolar, and after treatment lost bipolarity, and even with longer incubation, it has a long tail with disrupted function. Again, there are many signs denoting the macrophage that help intolerance. So this is the pathway ending in stimulating. When the macrophage acquire certain signs, certain designation here, you find it stimulate Treg cell and inhibit CD8 T cell. So at the end of the day, if we look at macrophage may help inducing intolerance and may help to induce rejection according to the local environment as shown by many investigators. The same for the role of the lymphoid neogenesis in allograft, and this can be considered as tertiary lymphoid organs. Accumulation of lymphocyte within the graft may denote rejection and may be associated with rejection and may be an index for tolerance according to the environment. One of the most important and exciting issues is to use Treg cell not as index for tolerance, but a therapeutic modality here for graft versus host disease, for the early onset type of diabetes, and this is the total dose injected, and this is the main results. But here I want to declare that still we are waiting because there is a study ongoing in renal transplantation. Secondly, the cost of Treg cell therapy is very expensive. The cost of treating only one patient is 30,000 UK pound or 45 US dollars per patient. Regarding the next sector is the pharmacogenomics. As you see here, the State of Union addresses President Barack Obama unveiled his precision medicine initiative, and one of the precision is the pharmacogenomics. The history of genetics in transplantation, I think, and this is my own thinking, it starts from the early beginning of the transplantation. As you know, the first successful transplant was carried out at Brigham Young Hospital, Harvard Medical School, by this genius doctor, Joseph Murray, the secret of success of the first couple was dependence upon the identical twin donor. And Professor Murray examined the donor and recipient medico-legally by applying the fingerprinting and other techniques to be sure that the donor is the identical twin of recipient. And this is why at that time, with the absence of immunological monitoring and the immunosuppressive drugs were in their infancy, the case succeeded without immune suppression because the donor is the identical twin of recipient. And then, what is the definition of pharmacogenomics? Pharmacogenomics refers to the relation between the human genetic profile and individual difference in clinical drug response. And the aim of pharmacogenomics is to optimize treatment outcome and individualized therapy. We have general guidelines, but we have a specific person with a specific genomic signature, and this pharmacogenetics is the discipline that translates information on genetic variability into prediction of pharmacokinetic. Pharmacokinetics means the behavior of the body with the drugs from absorption, distribution, metabolism, and elimination. Pharmacodynamics means the effect of the drug or the side effects of the drug. Was assumed the pharmacogenetic studies were assumed to revolutionize pharmacotherapy. And if we look at the metabolism, all these are genes concentrating on the cytochrome system. So a lot of genes for transporters and others, all these control the metabolism. And I think there is advancement in this field to the extent that currently we have these guidelines, Clinical Pharmacogenetics Implementation Consortium, guideline for cytochrome B3A5, the gene responsible about the enzymes that metabolizes tacrolimus. So if we have the genotype for this genetic polymorphism, I have either 1-1, this means that it is homozygous expressor, or 1 plus other, this means the heterozygous expressor. Expressor means metabolizing, fast, extensive metabolizing person. But if we don't have anyone, it's 3-3 or 6-6 or any combination without 1, this means that the person is poor metabolizer or non-expressor. Here, this is the guideline. If we have a patient with genotype of cytochrome B3A5 with an extensive metabolizer or intermediate metabolizer because of the presence of 1, this is a gene expressor, give 1.5 to 2-fold the suggested dose. But if you deal with a patient with poor metabolizer genotyping, cytochrome B3A5, give the standard dose. Again, still we are waiting further studies because this is one of the studies that just accepted within the American Journal of Transplantation, and the mass study included 240 patients. The assessing cytochrome B3A5 genotype based with body weight based tacrolimus dosing after living donor renal kidney transplantation in low immunological risk, they found no difference either to use or not to use this method. We have Dr. From the Patras University, Greece, Dr. Theodora. She discussed with us the issues of the pharmacogenomics, and we are going to have collaboration with her lab. Regarding the next generation sequencing, it revolutionized medicine and immune suppression because it offers the right drug for the right patient in the right dose at the right time. This is our goal for the best treatment of the patients. Again, the cytochrome and the polymorphism are not just studies are not just to know the dosages, but may predict rejection, may predict diabetes, may predict metabolism, as you see in this study. There is some correlation between the genetic polymorphism in this gene and the occurrence of new onset diabetes after transplantation with fasting blood glucose or body mass index. Regarding immunoexhaustion and senescence, this is one of the new articles discussing this issue, immunoexhaustion and transplantation. And here we should differentiate between what's meant by exhaustion, energy, and senescence. The difference between energy and exhaustion, energy, it is, we have to have good immune response, we should have two signals. The first signal is the antigen is exposed to the T cell receptor. The second signal is the presence of co-stimulatory molecules. So adhesion of co-stimulatory molecules strengthen the immune system. If the T cell receptor identifies the antigen, T cell receptor identifies the antigen, and there is no co-stimulatory stimulation, no adhesion between the co-stimulatory molecule, the cell will lose its interest and become allergic. So it's early. But exhaustion needs a long time of exposure to the donor antigen, and this is different, and to have the inhibition or exhaustion receptors or signals. And the senescence, this depends upon telomere, and I'll show it later. So the inhibitory receptors include programmed death one, TIM3, T cell immunoglobulin domain and mucin domain 3, CTLA4, cytotoxic T lymphocyte associated antigen 4, ETLA, B lymphocyte and T lymphocyte attenuator, LAG3, lymphocyte activation gene 3, KLRG, killer cell lectin-like receptor G1, CD160. So if we know these inhibitory receptors, if we can be able to induce them, to have them, and to be applied only for the alloantigen, so we'll keep the graft without rejection, and at the same time we have the immune system functioning against infection, against viruses, this will be very fine. And this is how this work occurs. If you have the naive CD cell with some action, you'll find here expression of the inhibitory and exhaustive T cell, and this is it inhibits the immune system. Again, all these are dynamic, so the cell may lose these inhibitory molecules and become effector again, so should be careful about that. And raising T cell exhaustion within the graft may help in tolerance, and this is one of the articles regarding T cell exhaustion, co-stimulation and clinical outcome in autoimmunity. So if the cell is not exhausted, this means that the cell can have immune reaction. And if the cell is exhausted, this may be correlated with certain disease. If you look at these markers, we will find some markers down in exhausted group, up in exhausted group, and no change. And this will be associated with certain problems. So if we stimulate immune exhaustion, this may be positive for transplantation. But at the same moment, it stimulates viral infection and malignancy, so we should be careful about this issue. Regarding immunosenescence, this slide summarizes the changes within the neutrophil, dendritic cell, macrophages with the age. And I mentioned this slide within the autophagy presentation. Here, the telomere length, the shorter the telomere of the cell, the shorter the lifespan of the cell. So we can measure the telomere, and here the shorter the telomere may be associated with adverse outcome in kidney transplantation. This is if we are dealing with senior patients, so it's better to have good matching, because good matching will avoid the necessity of higher immune suppressive drug dosages, and so this will be very appropriate for this patient to avoid infection and malignancy. Regarding transplantation in microbiota, this is a very nice and still naive area for transplantation, and this is one of the statements of this Nobel laureate who said we should think of each host and its parasites as a superorganisms with the respective genomes yoked into a chimera of source. We have in the colon more than 10 to the power of 14 microorganisms, and all these can, if we work with these microorganisms, we can play with the immunity. And this is one of the articles showing the clinical implication of basic science discoveries, immune homeostasis, and the microbiome, dietary and therapeutic modulation, and implication for transplantation. Since more than one decade, we have what's called immune nutrition, how to play with immune cells, with playing with nutritional requirements and nutritional therapy. Here the same through this system. So microbiota may promote neonatal maturation of pairs batches and lymphocytes, diffuse differentiation of derived differentiation of T effector cell, induce Treg cell, promote bactericidal function of neutrophils, reduce activation threshold of dendritic cell to improve antiviral immunity. So a lot of action can be done, and we have here, if we transplant complex organ including intestine and lung, you may have local inhabitant organism that play with the innate and acquired immunity. And this is one of the literature watch of bugs and drugs, how the microbiome control responsiveness to anti-tumor immunotherapy. This is the first articles. Commensal bifidobacterium promotes anti-tumor immunity and facilitate anti-PD-L1 efficacy. That was published in Science in November and last year. And this is another article, anti-cancer immunotherapy by CTLA4 blockade relies on the gut microbiota. So here, by the use of microbiota, we stimulate immunity, and this will be beneficial for the malignancies. But if we learn how to use microbiota to suppress the immunity and to allow acceptance of the organelles, of the transplanted organs, this will be another issues in dealing with microbiota. Regarding practice guidelines, the European Best Practice Guidelines were published online in 2014 and published in this issue of nephrology and transplantation in 2015. And regarding the sector of immunological workup, this chapter 2, and this is immunological workup of kidney and donor. How should, this is one of the first questions, how should we HLA typing be performed in renal transplant candidates and donors? The answer is, the guidelines suggest that at least one typing is performed by molecular human leukocyte antigen typing of patients and donors to avoid mistakes in the classification of HLA antigen. Again, we should look at the evidence between brackets. 1 means recommendation, 2 means suggestion, and A, B, C, D, strong, moderate, weak, very weak evidence from literature. We suggest that HLA typing is performed in duplicate, preferentially on separate samples obtained at different occasions to avoid logistic error. But it is ungraded statement. In case of sensitized patients, we recommend additional serological typing of the donor cells to be used for cross matches in order to check the proper expression of HLA antigen on the target cell. For highly sensitized patients with allele-specific antibodies, we suggest consideration of high-resolution molecular typing in both recipient and donors, and one of the highest resolution is HLA matchmakers and ablet matching. In renal transplant recipients, how should HLA matching be used to optimize the outcome? Here, the guidelines suggest matching for human leukocyte antigen A, B, and DR whenever possible. And they recommend balancing the effect of HLA matching with other parameters that affect patient and graft outcomes when deciding the acceptance of a potential graft. They recommend giving preference to HLA identical donors and recipient combinations because the better matches prevents the occurrence or help in prevention of occurrence of anti-HLA antibodies. This suggests giving more weight to HLA-DR matching, as we thought in our center, than HLA and B. They recommend giving more weight to HLA matching in younger patients in order to avoid broad HLA sensitization, which might impair retransplantation. Very interesting and practical guidelines. In renal transplant candidate, what HLA antigens and non-HLA antigens should be defined in addition to HLA, B, and DR? The guideline recommend performing human leukocyte antigen DQ, DP, HLA-C typing of the donor only when the intended recipient has HLA antibodies against those antigen, and they don't recommend at all routine typing for HLA-DQ, DP, or AC. They don't recommend routine typing for major histocompatibility complex 1 related to chain MICA and other non-HLA antigens in either recipient or donor. Very interesting. Except in special situations. HLA sensitized kidney transplant candidates, what measures should be attempted to improve the probability of a successful transplantation? This is the recommendation, and they recommend transplanting patients with donor-specific antibodies only if these above-mentioned measures cannot be accomplished and after successful intervention. And one of the intervention is to stimulate the acceptance of a mismatch program, etc. A renal transplant candidate should a failed allograft that is still in place be removed or left in place. Our experience, if we have graft failure early with hematuria, tender graft, we remove the graft. But if it is after a long period of transplantation, it is a difficult surgery. So we think of graft nephrectomy when there is symptoms, when there is inflammation, aggressive, resistant anemia refractory with inflammatory markers. So the guidelines, the evidence comparing patients with a failed transplant versus without nephrectomy is insufficient and conflictive, hampering a meaningful general recommendation on whether or not nephrectomy of failed grafts should be recommended. We suggest that in the following condition, an explantation means graft nephrectomy of the failed kidney graft be considered: clinical rejection, chronic systemic inflammation without other obvious cause of recurrent systemic infection. And this suggests an important, suggesting a low level of immune suppression to avoid nephrectomy of a failed graft when residual graft urine output is above 500 ml per day and there are no signs of inflammation. In renal transplant, what technique of cross-match should be used? The guideline recommended performing complement-driven cytotoxicity cross-match to prevent hyperacute rejection and suggest that in HLA antibody negative patients with negative regular screening samples, a cross-match can be omitted unless a potential HLA sensitizing event has occurred since last screening, and they don't recommend performing a Luminex or endothelial cell cross-match because their additional value needs a further evaluation. So virtual cross-match is not recommended, and also the endothelial cross-match is not recommended until become validated. They recommend that a positive CDC cross-match should only be accepted as truly positive when donor-specific antibodies are known to be present. So we should do Luminex testing just to be sure that the second safety for the patients who have cross-match, and we have anti-HLA antibody testing. If cross-match is negative, CDC cross-match is negative, plus negative anti-HLA antibodies by Luminex, this can give us security and safety. A renal transplant candidate planned to undergo live donor transplantation, but for whom the available donor is ABO incompatible, what measure can be taken to improve outcome after transplantation? They recommend both inhibition of antibody production and ABO antibody removal before transplantation applied together in one and the same validated protocol. And they recommend transplantation with ABO incompatibility only if the ABO antibody titer after intervention is less than 1.1 to 8 dilution. And they suggest considering paired exchange when available. In previously transplanted patients, what is the effect of repeated mismatches for HLA antigen on outcome as compared to avoid repeating HLA mismatches? They suggest that the presence of antibodies against the repeated mismatches detectable by other technique than the complement-driven cytotoxicity technique be considered a risk factor, not contraindication for proceeding. Here I reached the end of the all sectors I prepared, but I want to end with this quotation of William Osler, that medicine is a science of uncertainty and art of probability. And I've told you today many uncertainty, and you are still waiting a lot of validation, a lot of result, and still the immunology is one of the top secrets. What is my advice is to read and read and read. Although Voltaire said that the more I read, the more I acquire, the more certain I am that I know nothing. And it's not only reading, but also to have science, to have skills, because ego is inversely correlated with knowledge. The more the knowledge, lesser the ego, lesser the knowledge, more the ego, as Einstein said. And at this point, thank you very much for your attention, and I'll be happy to receive any questions on my email that you know. Thank you very much.